Today's webinar is titled Demystifying the Literature, an Introduction to Evidence-Based Medicine, presented by Dr. Tyler McCardell. I'm going to pass it over now to our presenter. Thank you so much for being here with us today to share your knowledge and experience with us, and we look forward to the presentation.
Good morning, everyone, and thanks, Rio, for that introduction. My name is Tyler McCardell. I'm joining you from Pittsburgh this morning, and we're going to talk about evidence-based medicine. So without further ado, we'll get going. Thanks for joining us, and I hope that you guys enjoy what we have over the next hour. As Rio mentioned, I will try to be responsive to questions that are thrown in the chat. So we'll just go from there. Feel free to ask anything if I'm not clarifying something, or if you want to ask something about another topic or related issue, please feel free to reach out. Okay. So just a little bit about me. So I'm originally from Lancaster County, Pennsylvania, in the central part of the state. I've done basically all of my training within Pennsylvania, between Pittsburgh and Philadelphia. Most recently, I have been the chief resident for emergency medicine residency program at Allegheny General Hospital, which is a level 1 medical center in Pittsburgh. And I will be starting in just a few days as one of the inaugural EMS fellows at the University of Pennsylvania back in Philadelphia. I have a pretty extensive EMS background prior to medical school. I was an agency administrator, EMS educator, and then when I moved out to residency, did some fire stuff as well, as you can see there in the bottom right. So I do not have any disclosures or conflicts of interest relating to the content of this presentation. Any products or services mentioned by name are incidental only and are not conveying a specific endorsement nor that of my employer. So first thing that we want to talk about is, why is evidence-based medicine important to EMS? And hopefully by joining us today, you've acknowledged that it is important and something that we need to do a better job of talking about. I'm sure that most of us are probably members of a Facebook group or 2 or 3 that are EMS related. And on those Facebook groups, it's probably a lot of conjecture, and well, one-off cases. Well, I saw this work once, but how do we truly make advances in our field? So evidence-based medicine is obviously going to be integral for approval of new medications and therapies, protocol development as treatment options change and we change how we approach things in the hospital. That obviously impacts how things are going to be used in the out-of-hospital environment. And just knowing what should be the standard of care, right? What should our paramedics and EMTs be operating and doing in the field? There's data to show us this and to tell us this and to help us make these decisions. And that data comes from the research. So having the ability to translate an evidence-based article into its direct application in the field is really something that's important, and something that our EMS providers, as they come through their education, should be getting exposed to. So just a couple quotes and cartoons that illustrate that point, right? The most dangerous phrase in the language is, "We've always done it this way." So as evidence changes, our practice changes, and something that was true in the 80s, 90s, 2000s, even 2010s may not be true today. And the only way that we're able to know that is by approaching the literature with an analytic mind. So what can we do about it? So my goal today is to help you improve your ability to form a search question, identify applicable literature, and interpret a journal article, so that you can say, I have a clinical question, or even I have an education-based question. What is the correct way? What should be the standard of care? How do I find a reliable answer and be confident in my approach to what I'm doing? So some objectives, we're going to, at the end of the presentation, be able to describe how to form a search question using the PICO method. You're going to be able to list at least 2 resources to obtain primary literature and identify potential sources of bias. You're going to be able to explain the concepts of statistical significance using p-values. And we'll be able to apply these skills to a real-world clinical question. So after we walk through some of the more foundational material, what we will be doing is I actually have an article with a QR code, and as we get to it, we'll kind of all follow along and explore how we can implement this in real time. So this is how we'll kind of go through the day here. We already covered our introduction, so we'll talk about forming a question, finding an article, how to read and interpret the article, and then we'll do the application exercise. Okay, so first things first, let's talk about forming a search question. So the first thing we ask ourselves is, what do I want to know, right? Why am I going to consult the literature? What do I want to know? Is it something about clinical care? Is it something about an operational decision? Is it something that's more educational theory based? All of these things and more can be addressed through the literature. It's just going to be a matter of maybe which articles we select or which journals and which other sources are going to give us an answer to our question. So in order to form a search question, we use what's called the PICO or P-I-C-O method. P stands for population, I intervention, C comparison, and O is outcome. And we're going to walk through each of these and explore a little bit more in detail what they mean. So for the population, we're asking ourselves, who is being studied? So it could be a specific subset of patients, pediatrics, women over the age of 50, post-CABG patients, or another clinical criteria. And we just have to ask, or it could be something more generic, right? All EMS patients, all comers. All of those are appropriate. The next thing we're going to ask is, what is our intervention? So what is being studied? It might be a medication such as albuterol, or an intervention such as whole blood, or in air transport could be portrayed as an intervention, right? But we are asking ourselves, what is the thing that we are doing to the patient? That is closely correlated to what's the comparison. So in a lot of like drug studies, this is compared to placebo, right? You give a medication, you give a placebo. If the medication has more effect than the placebo, then the medication likely works as designed and as intended. But that's not the only type of comparison that we can have. You can also compare something to the current standard of care. So for example, let's say a researcher was interested in adverse outcomes from long spine board immobilization. They could compare a more conservative approach with immobilization to a more progressive or liberal approach to a patient selection of who gets boarded, and then asking and then comparing adverse outcomes and how they define that would be part of their workup for their study. But again, it's not just a placebo. You can also compare two things to one another. So for example, albuterol versus albuterol hypertropium could be a potential comparison in a study. It all depends on what we want to know as the, not the researcher necessarily, but as the student, as the policymaker, what do I need to know to help me affect my clinical care or operational decisions? And then the final element of the search question is going to be the outcome. So how am I judging the intervention? Is it mortality? Is it time? Lights and sirens use, right? Could be time. Hypotension could be a marker of something. A Rankin scale, for those of you that are more familiar with research, that's something like an outcomes-based approach to functional disability after an event. So regardless what the criteria that we pick is, we want to make sure that it's the same for judging our intervention and our comparison groups. But it all depends on, what do I want to measure? So for example, let's take this question. And this is a question that might pop up, right? On a Facebook group, on a class discussion, on another environment, or in a protocol development committee, is, should paramedics give cefazolin? So when we take this and form it using a PICO method, you can see that we get a very specific, targeted, direct question. That's how we're going to form the search question to figure out where our data or what our data is showing. So compared with no intervention, is there a decreased rate of infection in patients with open fractures treated with cefazolin in the pre-hospital setting? So if we go through and walk this out, P, the population, would be patients with open fractures. So that's our subset. I, the intervention, this is going to be cefazolin or ANSEF. C, your comparison is no intervention. So that's okay, right? We're saying, should we do this thing? And we're currently doing nothing. So we're comparing the intervention to a comparison of null. And then outcome. And our outcome specifically here is decreased rate of infection. We could say, if you wanted to, you could say mortality. I'm not sure there's great data on that. But we're going to say, is there a decreased rate of infection? So we take a question that's commonly worded, and then we word it in a very specific format so that we target our search and find more relevant articles and research. Another example, should stroke patients be transported by air? So when we break it down, compared with ground transport, is there a decreased time to needle in stroke patients transported via air medical services in the pre-hospital setting? So population, stroke patients, intervention would be transport by air medical, comparison would be ground medical, and the outcome would be time to needle for TPA or TNK administration. So now that we've formed our search question, the next thing that we're going to have to do is find an article that hopefully has data to allow us to start to answer that question. So there's a lot of sources that we can use. PubMed is one you may have heard of. PubMed is an indexed database of published research in the medical field. NCBI is also a clearinghouse. Google Scholar is my personal favorite. So if you type in scholar.google.com, Google has, in a way, also indexed, but I think they also use like a PubMed link to scholarly articles. And when I say scholarly articles, I mean things that are published in peer-reviewed literature. So Google Scholar is a nice filter, right? If I typed in, should paramedics give ANSEF in just a normal Google search bar, I'm going to get a ton of results. That's going to be maybe Joe Schmo's paramedic blog, who he's just going to go on and on about this one instance where ANSEF had a negative outcome, right? Is that true data evidence-based medicine? No, it's not. Is that something that we want to kind of clog up our search results? No, probably not. So Google Scholar is a nice way to filter out that non-peer-reviewed, non-evidence-based fluff that is commonly biased by a normal search engine. So that's my 2 cents, and it's free to use. So Google Scholar is certainly helpful. And online library databases, for those of you who are affiliated with academic institutions or other educational institutions, a lot of times your libraries through your college, university, K-12 institution will pay for online subscriptions to databases that are indexed that you can get copies of articles from. So talk to your librarian if you have that access to that resource. If you don't, you have plenty of the ability to find these just using the normal search engines. So sources, other sources is you can consult a specific journal. So PEC is the journal that's widely respected in EMS, pre-hospital emergency care. Annals of Emergency Medicine also runs EMS-specific articles. These are just 2 examples of the covers of those. Once we've found articles and we get our search results, the next thing we have to think about is what type of study we are looking at. You're looking at potentially observational data versus investigational data. So observational would be the researcher is kind of apart from the process and is just an observer, a third party to what's actually happening. These can be retrospective. So looking back in time, right? Chart review for outcomes would be an example of retrospective data analysis, or it could be prospective. So I've seen studies where maybe you call like a day zero, and things that were done, like say intervention X was done previously, and then we have an implementation date, and now we have intervention Y. That's actually a nice, clearly cut way to separate and compare those two blocks of time. So let's say we were using our EMS agency was using long spine boards, and then we stopped using long spine boards. That could be an inflection point to say, okay, we're going to compare the data retrospectively to rates of complications pre-intervention, post-intervention. Prospective data is done as a designed project and then implemented, and then the data is collected afterwards. Investigational data, sorry, I kind of skipped over that one, is where the researcher is actively involved in changing a variable, whether or not that's police transport of trauma patients, or a new intervention, a new medication. That's going to be an investigational study. Randomized controlled trials, these are like the quote unquote holy grail of research. They're very hard to do, they're very expensive to implement, but they are recognized as the kind of highest tier, for lack of a better term, of medical research. Because with the controls, with the randomization, you're basically increasing your likelihood of showing a truly statistically significant result. Meta-analysis is the term that you may come through in your searches. A meta-analysis is essentially a conglomeration of other research. So let's say there are 10 different studies that have been done on, I don't know, albuterol versus Duonet. What an individual doing a meta-analysis may do is take all the data from all those 10 studies, put it into one analysis, and then run the data and see, okay, well, is this something that maybe one or two articles said was significant and another couple articles said was not? What if we conglomerate everybody's data and see with a larger data pool, does that change the results in some way? So how are we getting results, getting search results to find an article to analyze? Try searching by keyword and using broad terminology. Similar to how we would do a Google search, right? Excuse me. And eliminating unnecessary language, connecting terms A and highlighting those direct interventions and terms that are PICO terms are going to get you more specific results. Using Boolean searching, so these are qualifiers such as and or not. Example would be paramedic and cefazolin and fracture. If you wanted to be more specific using a not, you could use paramedic and cefazolin, not sepsis, right? Because I want data related to fractures, not sepsis-related antibiotic coverage. Not that ANSEP is a great coverage for sepsis, but you get the idea. So once we've found a source, we have to think about what makes this source reliable or not. We're evaluating whether this is a primary or secondary source. So primary literature is written by the author who conducts the literature, conducts the research and conducts the data analysis. Secondary has a degree of separation. Generally speaking, primary literature is preferred. So again, author performed the research directly, whereas secondary would be something like a meta-analysis, where your data or conclusions are abstracted from someone else's work. It doesn't mean that it's a bad study because it's secondary. It just means that you have to approach it with a grain of salt and be cognizant of the fact that this individual who's doing the research, doing the article, did not conduct the research his or herself. Other things that we can think about when deciding if we have a reliable source is the fact of peer review. So anybody can put something on the internet, right? I could write an article, quote unquote article, that looks real and has numbers with it and fancy graphs, and I can post it on my paramedic blog. but that doesn't make it right. That doesn't make it correct. Peer review is the process where if I want to do a research project, I do my data analysis, I do my collection, I write it up, and then I submit this to a journal, and the journal sends it out to my peers. If it's Annals of Emergency Medicine, it's going to be to emergency medicine attending physicians with years of experience in their field. They are going to read the article and be critical of it and say, okay, do these conclusions make sense? Was the research process flawed in any way? Is the data look realistic? All of those things go into saying, yes, as a peer of this author, I believe that their data and conclusions are correct and accurate, and I believe that there's a vested interest in sharing that with the medical community. So that process of peer review lends like a validation and a stamp of approval almost that this research is valid. There are journals out there that are non-peer reviewed. A lot of these are quote unquote like pay to play journals. So if I pay $500, I get my work published in this journal. There's a lot of controversy in that within like academic circles. Some of the pay to play journals are peer reviewed, some are not. So just be cognizant of, okay, what am I looking at when this journal, if I look at the Journal of Investigational Medicine in EMS, right? Totally fake. Is this peer reviewed or not? The other thing that we can think about is the impact factor. This is a publicly available piece of information about a journal. It essentially is a metric of how widely cited and like read and accepted is this publication. So if you think about maybe 3 examples here. So I picked out, believe it or not, this is a true journal, the Archives of Iranian Medicine versus Pre-Hospital Emergency Care versus JAMA. JAMA is the Journal of the American Medical Association. Each of these has its own impact factor. And here those impact factors are. So as expected, right, JAMA's impact factor is massive, 91. That's one of the most widely accepted journals in the House of Medicine, period. Not surprising that it has a super high number. PEC has an impact factor of 3, most likely because it's a very select community of practitioners who are reading and contributing to this journal. Whereas the Archives of Iranian Medication has an impact factor of 0.9. So again, not something that's an end-all be-all. Just because a journal has an impact factor of 1 or 3 doesn't mean it's a bad journal. It just means that you have to maybe take things with a grain of salt and make sure that you're doing your due diligence. Okay, is this peer-reviewed? Does the data make sense, etc.? So now that we've found an article and we validated it and said, yes, it comes from a peer-reviewed source, and it's a decent impact factor journal or one that I've heard of before, PEC, for example, how do we approach the actual article itself? So just like we have human anatomy, there is anatomy of the journal article as well. I did see a question pop up in the chat. How do you locate the impact factor? If you just Google the journal and an impact factor, there are publicly available databases out there that will show what the impact factor is. So it's a really easily searchable and easily identifiable piece of information. Anyway, so anatomy of a journal, just like we have human anatomy, right, there's journal article anatomy as well. The first part is the abstract, then the introduction, methods, results, discussion, and references. And we're going to go through and talk a little bit more about what each of these parts looks like and what each of these parts might include. The abstract I like to refer to as the Cliff Notes version. For those of you who were in school at any point and didn't want to read the actual book, you would go on Cliff Notes and get a nice summary of the Scarlet Letter or whatever piece of literature that you didn't feel like doing on your summer reading assignment or were too late to. Anyway, the abstract is a nice overview and summary. It's a couple sentences on the need for the research. It's a couple sentences on what they did, how they did it, what the data showed, and then the conclusions. So if you're looking to say, okay, is this an article that I even want to kind of go through more in a more detailed fashion. Is this applicable to what I want to know? The way to figure that out is basically read the abstract. And if the abstract is along the lines of the PICO question that you're searching for, great, include that in your search and something that you can read more about later. Whereas if the abstract is talking about things that are unrelated, then that's a good way to say, without reading the whole 72-page article, right? That's a good way of saying, it's probably not worth my time. This is not directly applicable. Now, if I can't find something else, I might come back to it later, but I'm going to use my time elsewhere. The introduction has a lot of background. Oh, sorry. An introduction has a lot of background knowledge. So this is maybe a discussion of work that's been performed previously by other researchers. What's the standard of care, what's known within a field. It's all the essential background information. Methods, as self-explanatory, right? How was the study and work done? They're going to describe how data collection was performed, how the intervention was done, how the data was analyzed is also in here. And you can really get through the nitty-gritty and see the procedures of research that were done. Something to think about here is controls and blinding. So controls, sorry, keyboard sensitive this morning. So controls would be research tools that help ensure validity of results. For example, if you have a population group with a comorbidity, so let's say that there's a population of diabetic patients that also have hypertension. So diabetes and hypertension are comorbidities that occur together potentially. If we only want to talk about diabetes in our research article, then the authors are going to have to be very careful about how they control for hypertension. Because if we don't control for that and those two factors are linked, it can become what's called a confounding variable, and it can kind of complicate the applicability of the research to say, okay, is what we're asking about truly due to diabetes, or is it maybe impacted by hypertension as well? And then blinding. The concept of blinding, we're probably familiar with. This is the concept that a researcher ideally does not know what intervention is taking place in their populations. Sometimes very hard to do, right? If it's an intervention like ground versus air medical transport, it's essentially impossible to blind what's happening, right? Everybody can see the helicopter land. It's not gonna fake us out about that. Placebos are a form of like control blinding. So you're giving a medication versus you're giving just saline. Saline is a widely accepted placebo. So in that way, if the medication, for any of you who are involved in the Pain Lights study network, I know our health network is, this is a blind study because you basically get a little brown study kit of medication, and the paramedic or PHRN or other pre-hospital provider just gives that medication, and they don't know what it is. It's either fentanyl or ketamine. That's an example of blinding. That way you don't influence the results, right? Let's say I'm a big ketamine fan, and if I were a researcher, I'd say, oh yeah, well their pain relief went from 8 to 3. Oh, I'm giving fentanyl. Oh, their only pain relief only went from 8 to 5. So it's a way to blunt subjective interpretation of the data that could be biased by knowing what's going on. Results is all the hard data in charts and figures, as well as explanation. So always pay attention to the scale, right? For those of you who are watching the screen, this is a great example of a scale gone awry. So what's wrong with the graph on the right? Take a second here and see if you can find the graph on there. In the top right, the like newspaper clipping. What's wrong with the bar graph? So if you look carefully, right, look at the scale. The scale starts at 420,000. So this is a publication by the Time, probably the Times of London, I would presume, saying, oh, we have 485,000 full price sales, whereas the Daily Telegraph has 446,000. But if you didn't look at the numbers and you only looked at the graph, what's the conclusion that you would reach from that bar graph? You would reach the conclusion that the Times has sold more than double the subscriptions of the Daily Telegraph, and it's clearly superior, right? Whereas in actual data, it's only 10%, it's less than a 10% difference. So just be very careful about the scale when you're looking at research articles and charts and figures. The next part of the analysis, or sorry, our journal article is the discussion. So this is where the authors are able to say, look, this is the data that we obtained. This is what we think it means. What are the implications and applications? So they're going to answer their questions. They're going to maybe compare to other work that has been done in the past. Excuse me, sorry. They're going to talk about their interpretations, potential limitations, and then kind of where do we go from there. Conclusions can also be a part of this. Conclusions, basically, this is what we recommend as authors. This is potential work that could be done, along those lines. And then references, right? Just like we know in academic medicine, we don't want to plagiarize things. So we want to always cite the work that has been done before us. So what prior work influenced this paper study and the list of references that are indexed. So that's the anatomy of the article. Once we get down to examining the article, a couple things that we want to think about. We want to think about bias, right? Is there any undue influence on the work? So some examples of bias could be sponsorship. Let's say pharmaceutical company A is putting out a new drug, and they find a researcher who is willing to accept a multi-million-dollar grant to do research to demonstrate if drug A works. I'm not saying that researcher A's conclusions are necessarily bad, right? It could be that drug A does very well work and that drug A is massively helpful to patients. But we just have to examine this with a grain of salt, right? That there's the potential for bias, the potential for someone to have a vested interest in the outcome of research and the outcome of a work. We're all human, unfortunately, so we just have to be cognizant of that when we review. Sponsorships are most often disclosed by the authors within their authorship block. So they would say, basically list the authors and maybe a little asterisk or number one and say, John Smith has a disclosure that he or she received a $3 million grant from AstraZeneca Pharmaceuticals to conduct this research. Something like that. Right? Follow the money. And just think critically, right? This is, at the end of the day, we have to be able to say, okay, this is data that makes sense, or this is data that doesn't make any sense. Lots of potential error there, but we are thankfully blessed with good heads on our shoulders, and we have framework to evaluate these articles like we've talked about. So when we're talking about outcomes, there's a couple different types of outcomes. Primary outcomes are the intended result in focus. So let's say I was going to design a randomized controlled trial with pre-hospital ANSEF, and I had groups of paramedics that were giving ANSEF and then groups of paramedics that were giving placebo. So I'm blinding. I'm now going to figure out what's my primary outcome. It would probably be rate of infection developed during the hospital stay. That would be my primary outcome that said, this is what I'm measuring. I am measuring rate of infection in patients. However, that's not the only thing that we often report in these articles. The other type of result is called a secondary result. So a secondary result is something ancillary. This could be something incidental, or it could be something intended. The good examples of these are if you look at the pre-hospital blood studies that have been done. A lot of these are done actually out of UPMC in Pittsburgh. The primary results are sometimes not significant. So overall mortality might not change, but at a secondary data point, so let's say mortality within 30 days for a specific subset of trauma patients did improve substantially. that is helpful to us because it says, okay, maybe blood or intervention X doesn't help everybody, but maybe there's a particular population that it does help that we really want to focus on. That opens up an avenue for potential future research and helps us with protocol development and kind of further steps. So just looking at, was our result a primary or secondary result? Sometimes what you'll see, actually, I think I get to it next, is the analysis that was done. An a priori analysis is declared before the data is obtained. So if I want to get a project approved by the review board, I have to say, okay, I'm going to examine the rate of infection with pre-hospital open fractures, as well as mortality, I don't know, maybe hospital length of stay. And those are my three things that I'm telling you up front I'm going to analyze before the data is collected. And then let's say we collect the data, and then when I'm analyzing it, I notice that for some weird reason, in diabetic patients, ANSEF had a really significant benefit in prevention of infection over non-diabetic patients. I might then choose to do that analysis and see what the data shows, and I might be able to declare something that's statistically significant. That would be a post hoc analysis. So the data is done, I see something interesting, and then I analyze it. Doesn't mean that the data is flawed, doesn't mean that it's bad data, it just means that we have to be critical about how we think about the article and about the impact of it. Generally speaking, a priori analyses are considered ideal. But post hoc analyses certainly have validity as long as the statistics make sense. Speaking of statistics, everybody's favorite line. So thinking back to high school, right, we all took a statistics class at some point or after that. How are we making sense of the data? A couple of things that you're going to see when you're looking at a research article. N is referred to the sample size. So this is how many people, patients were involved in the study. And then there's this whole concept of significance. Significant is a charged word in the research community because you need to be very careful about how you use it. If you're saying that something is significant in an article, then unlike the common language that you or I might use just talking to one another, right? Significant has a very specific connotation within the research and academic community. And it means that the statistics show that the odds of a chance result are very, very low. And we'll talk about what very low is. But it means that the data supports this argument when I say significant in a paper. You'll see this little symbol. This is the alpha value. This is the acceptable risk tolerance. This is picked by the researcher. So this is basically the probability that the result you obtain as the researcher is a chance. Think about flipping a coin, right? If you flip a coin enough times, you're going to get some weird results. You might get 50 heads in a row. What are the odds of getting 50 heads in a row? Really, really, really low, but not zero. So as a researcher, the researchers are saying, what are the odds that I show that masked trousers really work, for example, right? Well, the odds are not zero that masked trousers do work. What am I going to accept as my probability of chance? Typical values are 0.01 or 0.05. That translates to a percentage. So this is essentially me saying, well, this is a general kind of interest piece of research. I'm going to accept a 5% risk of error here. So if you use an alpha of 0.05, you would be saying anything below that, I'm going to call significant, which means that there's a 5% or less chance that your result was only due to chance, right? That the statistics that you showed were actually one of those times where you get 50 heads in a row. 1% is used in a lot of like strictly medical or legal implications. 5% is probably the most common alpha value that you're seeing. Again, what that translates to is a 5% chance that the data obtained is only due to chance, not due to the actual impact of the intervention. So it's the acceptable chance of a false positive. Significance is the p-value. So when you do the data analysis, your t-test, your z-test, your chi-squared, whatever advanced statistical methods you use, you're going to spit out a p-value. And you're going to compare that p-value to your alpha value as the researcher. That is going to show you your numeric probability of obtaining that due to chance. So again, and if you look at it in purely statistical language, it's the probability of rejecting the null hypothesis when the null hypothesis is true. It's the chance of a false positive. So if your P, your probability, again, this is from the data, if the data set probability is less than your alpha, less than your acceptable chance of a false positive, then your overall test result, your study result is positive, and the hypothesis is determined that to be true. A lot of times when you're reading research articles, you'll see a little asterisk, either in the data, in the bar graphs, in a chart. That's what this means. So this means the little asterisk means that it is statistically significant. If your P is higher than your alpha, it means that you do not have enough evidence to show that your intervention was statistically significant. It doesn't mean that you're wrong, right? Let's say that we do the NAEMSE thing and I do all this data and I show that my p-value is 0.06, just above that threshold. What that means is that there's a 6% chance that all my data was result to chance alone. So in 94% of times, right, NSF would have a benefit on infection, but that 6% is not enough to call out statistically significant. So I don't have enough data to show what I was maybe hoping to show. So it doesn't mean that the opposite is true. It doesn't mean that NSF doesn't help, but what it means is that I don't have enough evidence to show that it does. So for an example of how we would walk through this, right, there's a paramedic researcher wants to know if lights and sirens transport is going to have a benefit on mortality. The researcher sets the benefit, or sorry, sets the alpha at 0.05. That's a 5% chance of a false likelihood. You do your data set. These are your bar graphs. Your P is 0.023. So your P value, so this is your percent, your data analyzed set, shows that only a 2.3% chance that this is result, or sorry, 2.3% odds that this data is a result of chance, versus your alpha is 0.05. So your P is less than alpha. So P is less than alpha, which means that this is a statistically significant result. So what have we learned so far? Let's review and kind of go through some of these items. We've talked about where to find information. We've talked about generating a search question using the PICO method, population intervention, comparison, and outcome. We've talked about sources of journal articles, how to look at an impact factor, how to examine data and reliably look at this to say, okay, what are my p-values? What's an N? What's this asterisk mean, right? So what we're going to do now is we're going to put our knowledge into action for the last 15, 20 minutes or so of this presentation. So for the purposes of argument, we're going to say, should EMS providers insert supraclonic airways in cardiac arrest? So that's our clinical question. We're going to make this a PICO question, and we're going to say, in patients with out-of-hospital cardiac arrest compared to standard resuscitation, is there an improvement in CPR quality with early insertion of a supraglottic airway? So population, out-of-hospital cardiac arrest, intervention is supraglottic airway, comparison to standard resuscitation, and outcome, CPR quality. Not mortality, right? CPR quality. So where do we go to search for information? What terms do we want to use? So this is an example of a Boolean search, EMT plus supraglottic airway plus cardiac arrest. And you'll see an example of some of the results that pop up in Google Scholar for that. And let's say we find an article, we're going to look to see if it's reliable. Is it timely, right? Was this published in the 90s? And there's been a lot of work after that, or was it published 6 months ago? Is it primary or secondary literature? We talked about that. We know what those terms mean. And is it applicable to our question? Did we read the abstract and it's something that we're interested in? So I did a little bit of the background work for you guys. I selected an article. So if you want to kind of play along, for lack of a better term, and read the article yourself, this is a QR code that will take you directly to the article that we're going to be looking through. I also have screenshots that are going to come up on the PowerPoint itself. So if you can't get this up or don't feel like scrolling along on your phone, we're certainly going to have things up and walk through it a little bit. I'll give you guys a second to pull that up if you'd like. So, so here we go. So this is our abstract, right? And I'm not going to read this to you. We're not going to spend a ton of time walking through each term, but I just want to get you familiar with the general terminology and general flow of things. So the abstract talks about their setup, it talks about their data analysis, and it talks about their most important result or their most significant result, and talking about also like what's future directions, right? So my apologies. Basically, their major conclusion is among 13 teams of 2 participants, early insertion of an IHL resulted in higher chest compression fraction during the first 2 minutes. However, compressions were shallower in the IHL group, and they're saying we don't really know why that happened. This is a good example of an avenue for potential future research. So but what we have to ask ourselves when we're looking at the abstract is this something that's applicable to my search question? And I would say yes, right? It's EMS providers who are inserting a supraglottic airway and examining data regarding chest compression fraction, which is a part of CPR quality. So I think this is a pretty good article for what we want to know. So we've read the abstract, we say, yes, we want to read more and we want to learn more. So now we're going to talk about, or now we're going to look at the background. This is, again, all the previously done information, talking about prehospital providers training in endotracheal intubation, supraglottic insertion is quicker, and then it talks about hypothesis. Their hypothesis is that early iGel is going to improve chest compression fractions, and then they clearly lay out their objectives. Materials and methods, so this is their study design, right? Multi-center, parallel, randomized superiority simulation study. So what those terms mean, where it's basically occurring in different centers, you're randomizing the groups that are participating, and superiority is you're showing one thing it should be better than the other. And simulation, obviously, these are not real patients, so these are mannequins that are being used. Setting, so this is actually a Swiss study, interestingly enough, talks about training and all of the setup there. So we read our abstract, we read our methods, it seems to be reliable so far. Now we can go on to the results. So when we're looking at the results, we're thinking to ourselves, what do we think of the data? Does this data make sense? There's a lot of broken down information here. So this is the table 2, chest compression fraction by minute. So it's by time frame, by cycle of CPR. And you see, if you look over here, right, p-value. So this is p-value. This is showing that between the standard approach and the experimental approach, between these two approaches, the difference, was it significant or not? So these p-values, they're very, very low. We now know, because we are well informed on statistics, that all of these are significant with an alpha of 0.05. So what that means is that there is a difference between the standard approach and the experimental approach. If you go down here to the lower whisker plot, you'll see also difference here, although there's no asterisk to show significance on the whisker plot. Looking at proportion of ventilations that are above target value. So I believe blue, yeah. So blue is the standard approach, red is the experiment, or sorry. Yeah. Blue is the 5 centimeter. I'm sorry. Blue is the less than 300 milliliter volume. Red is the 300 to 700 ml. So red is saying, yes, this is the target volume, target value for ventilations. Blue would be below target value. Green would be above target value. Mean ventilation volume is higher. It gives the p-scores, right, to show that we have more statistical significance. And then once we look at the data, we're going to go through and look at the discussion and the conclusions. Do they make sense? Do they reflect the data accurately? Sometimes you'll read a conclusion and say, wait, that does not match with the data that was presented. Every once in a while, conclusions like that will slip through. So when we look at the discussion, in the simulation study, the immediate insertion of an eye gel device led to significantly higher chest compression fraction, and it attempts to explain why they think they got these results. And overall, we read it, and they talk about, oh, look, in contradiction with the VOTE study, but similar to Sarah Quesada Sanchez's findings. So you're comparing your work to previously done literature, and saying, look, this is a difference that we have, and this is why we think we have a difference. Versus, you know what, this is consistent with things we've found in the past, which should lend more credence to my results, right? And basically, what does this mean? Strengths and limitations. So this is where the researchers and the authors are able to say, these are things we did really well, and these are things that in hindsight, maybe we would have done differently, or maybe are opportunities for improvement if someone else were to do another or different or similar study. Outcomes, multi-center design, and I believe that they also talk about the chest compression depth being a limitation, and necessitating further research. So what are the overall takeaway points and where do we go next? This is the conclusions. So this is where we're talking about chest compression fraction. Overall, it was higher within the supraglottic airway group. However, chest compressions were shallower when the eye gel was used. So overall, what they're saying is further research needs to be done before we can firmly recommend that supraglottic airway insertion is superior to standard resuscitation. And they also acknowledge in the limitations that this is a simulation-based study, right? We know that mannequins aren't perfect models of human behavior, human physiology, and they talk about that being another potential avenue. Here at the bottom, you can also look, right, funding. So you see, was this funded by the iGel company? Was this funded by someone else? IRB, this is where the institutional review board says, yes, we approved this. And then author contribution is what each person did. So if we go back to the PICO question, right, we say, in patients without a possible cardiac arrest compared with standard resuscitation, is there an improvement in CPR quality with early insertion of a supraglottic airway? So the beauty of research and the beauty of all of this is that the answer is somewhat open-ended, right? Two people can read this article and come away with different conclusions. Oh, sorry. So two people can read this article and come away with different conclusions. That's the beauty of research, right? One EMS director might say, you know what? I really see a lot of value in this study. We should maybe change our resuscitations to include early supraglottics. Another director, another training program institution might say, you know what? I agree. There's not enough data out here, but let's go and try to get that data. Let's use that as motivation for further research. But at the end of the day, what this allows us to do is have an intelligent, evidence-based discussion about the data, about the research, and about the interventions that are going to impact the patient care that we do. It's not based on conjecture, right? It's not, well, one time I saw an eye gel fail, or one time my paramedic couldn't get a tube. This is actual data analysis, hard information that we can use to support or refute an intervention when we're in the meeting room, when we're in the classroom, when we're in those training committee meetings. So in review, research makes a difference in pre-hospital care, right? It's protocols, it's new medications, new interventions. We use the PICO method to develop search questions and find appropriate literature using databases such as PubMed, Google Scholar. We've learned about the terms such as bias, significance, and outcomes, what those means, and we've learned basic statistics, how to look at an article and say, I know what an N is, I know what a P is, I know what significance means, right? The degree and chance of a false positive is low. So all in all, I hope that you guys learned something you can take away from this class and take away to your future students. again, I can't stress enough that to be highly respected within the House of Medicine, EMS needs to adopt evidence-based practices and have evidence-based discussions using the data. And this is a great foundational tool to allow our students and allow ourselves to have those discussions on a high level. Okay, so again, thank you for your time. If there are any questions, I can hang around to answer those, but I hope you enjoyed it, and thanks for giving up an hour of your day to